Every time I do one of these talks, I like to think about what I hear in the office all the time. And statins are always a very hot topic. I think part of the reason is that people take them and they don't feel any different. And they question whether they're actually doing something. And then I hear a lot of questions, of course, about people who adopt plant based diets. And the question is, can I stop my statin? So today we'll talk about heart health without the pills, the statin question. So as we know, statins are commonly prescribed for preventing heart disease, but we also know plant-based diets can lower cholesterol and improve heart health. So we are going to have an evidence-based chat, meaning we are going to look at the scientific evidence about how we can balance statin use with plant-based diets. All right, what are statins? We're going to discuss why do we prescribe them. We're going to talk about primary versus secondary prevention and what that means, risks and benefits of taking statins, the role of plant-based diets, and also common questions that we see about statins. So what are statins? So first of all, why are we even talking about these? They are one of the most prescribed medications in the world. They are very important for preventing heart disease and stroke, but also a big source of controversy. So statins, commonly prescribed, over 35 million Americans take a statin. They are among the top 5 most prescribed drugs globally. Why are they so commonly prescribed? Well, we know heart disease is the leading cause of death worldwide, and statins directly address one of the main drivers, which is that LDL or bad cholesterol. So how do they work? So statins inhibit an enzyme called HMG-CoA reductase that is in the liver, and that thereby reduces LDL production by somewhere between 20 and 60%, which I know is a bit of a range, but we still see a significant improvement in people who take them. So not only do they lower cholesterol, they do a few other things. They reduce inflammation in the blood vessel, and they also help stabilize plaques. So it's not good to have a plaque. It's certainly not good to have a plaque. But if you do have a plaque, it's better to have a stable plaque. You can see here how there's a little more fibrous tissue around the plaque on the right that prevents it from rupturing quite as easily. And according to the World Health Organization, up to 80% of heart disease and stroke can be prevented through addressing lifestyle factors. That's tobacco use, unhealthy diet, physical inactivity, alcohol use, etc. And by addressing lifestyle risk factors, it doesn't only mean adopting better lifestyle changes or lifestyle habits, but also using things like statins that can address or help to combat things like a poor diet. Obviously, the first thing I will always prescribe is a more plant-based eating style, but we need to look globally at each individual situation. So we definitely know that LDL, which is our bad cholesterol, is a risk factor for atherosclerosis. Does high LDL cause heart disease? It certainly does. You will hear all sorts of stuff in the media. I love Dr. McDougall's quote, "People love to hear good news about their bad habits." There was a study that came out about 10 years ago that, anyway, it was a meta-analysis, and I'm not going to go into all my griping about it, but, they decided that they couldn't draw any conclusions, and from that, people concluded that that meant that LDL doesn't matter, but that is certainly not true. It has been very well established in the scientific literature that high LDL leads to atherosclerosis or buildup of plaque in the blood vessels, and that by reducing LDL, you will greatly reduce your risk of heart disease. So this is really the consensus among expert physicians and scientists. So here in this graph on the x-axis, we see it says magnitude of exposure to lower LDL, which pretty much means, dose and consistency of statin use. And on the y-axis, we see proportional reduction in risk of heart disease. And the bottom line looks at randomized controlled trials that follow patients for up to 5 years. We see a significant improvement. The middle line looks at prospective cohort studies, also a very linear relationship. And then the top one looks at randomized studies. And as you see, as we go from red to gray to blue, the follow-up gets longer and longer. It goes from 5 years to 12 years to 52 years. So pretty much what this means, not only do statins definitely work, but if you take them for a longer period, you're more likely to see a positive result. Okay, so let's talk about primary prevention. So this refers to individuals who do not have a diagnosis of cardiovascular disease, but we may consider statins if they are high-risk individuals. So statins will significantly reduce the risk of first heart attack or stroke in these high-risk individuals taking statins for primary prevention. Secondary prevention refers to people who have known cardiovascular disease. They've had a heart attack, they've had a stroke, they've had a coronary calcium score that shows significant atherosclerosis. In these individuals, we have even greater evidence that statins are effective. So they reduce the risk of recurrent heart attack, stroke, and death from cardiovascular disease by 25 to 30%, which is significant. In the real world, when you look at meta-analyses, we see that if we take a statin, we may drop cholesterol about 39 points, and that will lead to a 20 to 25% reduction in major cardiac events. So that's definitely a significant impact. So for patients at risk or with prior events, so this means primary prevention or secondary prevention, statins provide some reassurance that they are moving in the right direction, taking steps to prevent recurrence. Again, a plant-based diet is very important, but I want to focus on the science behind statins here before we get into that. And statins are also a proven therapy backed by decades of research, a lot of which we just looked at. However, they're also a major source of confusion. There's a lot to read online. I suggest avoiding most of what you can read online. People ask all sorts of questions. Do I really need this? What about side effects? Can I fix this with diet and lifestyle instead? Some patients fear statins more than the heart disease they're meant to prevent. I had one individual, we'll get into some of these details down the road, he has familial high cholesterol with an LDL of 220, which is way too high. We want LDL under 100 for low-risk patients and under 70 or 80, depending who you ask, for high-risk patients. So he was so concerned about side effects that, he didn't even want to take a statin, despite the very known high risk of heart disease with familial high cholesterol. So unfortunately, there is a lot of misinformation out there, and we need to be able to sift through it. Media headlines and social media clearly amplify the skepticism. I've only been in medicine 15 years or so, but I've seen a huge change just over 15 years. I think 15 years ago, people were much more trusting of medical providers. And in today's world, everyone wants to do their own research and make their own decisions. In some ways, that's a good thing that people are invested in their health. However, not everyone has the background to be able to understand some of the nuances in these headlines. Yes, your doctor is a great resource. If you have questions, that is a great place to start. Even if a doctor says something that you don't believe or you don't understand, you can ask for clarification. Can you send me a resource that, helps me to explain? Statins are not good or bad. They are tools. I had one patient tell me that she thought statins were evil. They definitely are not evil. They're just tools. I'll say often in the office, I will consider all tools available to us in our toolbox. Even when, back when I was single, I didn't want to meet someone online. I wanted to meet someone organically, but I still got on the dating apps because I was like, I'm just going to use all the tools available to me. So statins are a tool. My goal here is to help you feel informed and empowered so that you can discuss whether or not you need a statin with your doctor. So why do we prescribe statins? We're going to look at 4 main scenarios where we prescribe statins. Number 1, and this is a case of primary prevention. So people without cardiovascular disease but at high risk. First example of that would be anyone with an LDL above 190. This is typically a red flag for familial high cholesterol. We definitely recommend a statin in this population. Occasionally, I see LDL as high as this or close to this high in people who are on a keto diet. So those individuals, I would give them a chance to make a change. But definitely if LDL is above 190, that suggests familial high cholesterol, and a statin would be recommended. Number 2, also looking at primary prevention. So people without cardiovascular disease at high risk. So anyone ages 40 to 75 with diabetes. Diabetes is also a cardiovascular risk factor. So that's going to put you at higher risk inflammation and plaque buildup. So those individuals, a statin would be recommended. Also, anyone with elevated ASCVD risk. So this is a confusing subject. That stands for atherosclerotic cardiovascular disease risk. So this really means your calculated 10-year risk of having a heart attack or stroke. You can Google MedCalc, MDCALC, and type in ASCVD risk, and you'll find a calculator here where you can input all these parameters: your age, do you have diabetes, cholesterol numbers, blood pressure, do you smoke, etc. And it will output a score. And if you've had a physical done recently, at least I know in our system, this is something that's automatically calculated, or I look at this in anyone high cholesterol in this age range. It may even be jotted down in a recent, physician note. So anyone who has a calculated ASCVD risk above 7.5% generally benefits from a statin. So this is another place that's difficult for people to wrap their mind around. I tell people statins are not to treat cholesterol. That may have been sort of the old way of using statins. The current way of using statins is treating heart disease risk. If you are at risk for heart disease or stroke, we will recommend a statin. So we're looking at much more than just the cholesterol levels. Okay, so that's the third scenario in which we might recommend a statin in cases of primary prevention. And MD-Calc, ASCVD risk. This is also really fun because you can make lifestyle changes and these parameters change and your numbers change. I definitely have done this with patients who adopt a plant-based diet. Obviously, there's some things you can't change, your age, your gender, etc. But you can get rid of your diabetes, you can lower your cholesterol, you can lower your blood pressure, and you can see that ASCVD risk score go down. Okay, why do we prescribe statins? The fourth scenario here is in secondary prevention. So anyone with a history of cardiovascular disease, that means heart attack, stroke, or TIA, which is a mini stroke, any coronary revascularization. That pretty much means if you've had a stent or bypass surgery, or peripheral artery disease. So that's vascular disease, not in the heart necessarily, but in peripheral places like the lower extremities. So why in this group? We know they greatly benefit. Statins will reduce the risk of another major cardiovascular event by about 25 to 30%. Okay, so who may not need a statin? So low-risk individuals with no cardiovascular disease, diabetes, or major risk factors, and ASCVD risk less than 7.5% or less than 5%, depending who you ask. So low-risk individuals may not need one. Older adults over age 75 without prior disease, the evidence is less clear in this group, so the decision is always going to be individualized. And then people making major lifestyle changes. For example, they've adopted a plant-based diet, they've lost significant amount of weight, they've overcome their diabetes. These individuals may be candidates for deprescribing in primary prevention under physician guidance. So that all goes back to that ASCVD risk calculator for a lot of people. If you can reduce your risk using lifestyle changes, that may mean that you do not need the statin, but obviously that's something you'll want to discuss. And it's not, you need to make the lifestyle change, and you really need to show that it's sustained. I have some patients eager to adopt plant-based diets, and I'm eager for my patients to adopt plant-based diets, but you just don't want to stop statins immediately. You want to see the progress, and then once you've made significant progress, then it's time for that discussion. Let's look at some of the risks and benefits of statins. So obviously, they lower LDL cholesterol. 20 to 60%. They reduce our risk of heart attack, stroke, and death from these causes. And we know, as we mentioned, benefits are strongest in secondary prevention, but also present in primary prevention. Overall, statins are well tolerated. They are one of the most studied medicines in history. Most people do real well with them. Most people do not experience serious side effects. Again, I know you can go online and read all sorts of things, but just because it's been reported doesn't mean you will experience it. Many reported symptoms in the real world are often unrelated to the drug. They call this the nocebo effect. I think we see this in all areas of life. You see this when people say they got the flu from the flu shot. They may report a relationship that may not actually be causal. So always something to think about. Muscle aches would be the most common complaint. They're usually mild, usually affecting the large muscle groups like the thighs, the shoulders, often reversible with a dose adjustment or switching to a different type of statin. They occur in about 5 to 10% of people. In clinical trial, that's the percentage of people who say they have muscle aches and so they stop taking it. However, if you look at randomized controlled trials, it looks a little bit lower, like 1 to 2%. So in a randomized controlled trial, they're going to take, one group of patients and give them a statin and another group of patients give them a placebo and see what side effects are reported. So I presume that means of the ones who were on it, 5 or 10% of them experience effects, but then in the other group, it was probably 3 to 8% who also complained of muscle aches despite being on a statin. So that's kind of how you get that 1 to 2% in randomized controlled trials. Rhabdomyolysis, rare but serious. I think when CrossFit was real hot 10 years ago, this was more in the news. I've never seen this in, outpatient clinical practice, but basically severe muscle breakdown leading to kidney injury. This is a very rare side effect of a statin, less than 1 in 10,000. Again, I've never seen this in my career. Liver, mild elevations in liver enzymes occur in less than 2% of patients. It tends to be mild to the point where it is not significant and typically would not be worth stopping the statin. Routine monitoring is not typically recommended, though in a lot of patients it's done anyway during, the annual visit. Diabetes risk. So statins may cause a slight increase in blood sugar, and in turn, a slight increase in risk of new onset type 2 diabetes. The estimated risk is pretty low, about 1 additional case of diabetes per 255 patients treated over 4 years. Again, still for the vast majority of these patients, the cardiovascular benefits outweigh the diabetes risk for almost all patients, especially those in secondary prevention. Cognitive issues, brain fog, memory problems, these are really reported anecdotally. Large studies and FDA reviews found no consistent evidence that statins cause dementia or major cognitive decline. Some studies suggest statins may actually lower risk of dementia, especially vascular dementia in the long term. Vascular dementia is dementia related to the blood vessels that feed our brain. So if we can protect those and prevent plaque buildup there, that typically protects against dementia. Potential side effects, insomnia, vivid dreams, occasionally reported, not consistently proven in controlled trials, so I don't really have a percentage to share with you. Key point, most people tolerate statins well. I tell patients, I have some patients who are anxious about potential side effects. I'm like, well, just start it, just start it, see how you feel. If we have side effects, we'll stop it, we'll address it, we'll revisit. When we do have side effects, for example, muscle cramps, they're often manageable. We can lower the dose. We can switch to a different type of statin, or try alternate day dosing in patients who are sensitive. So there are certain statins that have an even lower risk of muscle cramps. So those would be the preferred ones that we would switch. Okay, so the benefits of statins in preventing heart attack and stroke almost always outweigh the risk. Here's the big question. I adopted a plant-based diet. Can I stop my statin? I see this question all the time, and I usually answer it in conjunction with a cardiologist. So the short answer is sometimes. In carefully selected primary prevention, patients whose overall risk becomes low after sustained lifestyle change. Rarely in secondary prevention, right? If you've had a heart disease diagnosis in the past, your risk is going to be higher. Statistically, you'll do a lot better if you stay on a statin. The decision should always be made with a healthcare provider. It's going to depend on a lot of things: your age, cholesterol levels, overall risk score, cardiovascular disease history, and really don't recommend stopping it on your own. So a statin is not a moral judgment. It is a tool to lower risk. If your true risks fall, so this is that ASCVD risk, meaning your LDL goes down, your blood pressure goes down, your weight goes down, your diabetes status changes, you no longer have diabetes, you stop smoking, etc. We may be able to adjust this dose, but obviously something to discuss with your physician. Okay, so what can a plant-based diet do? So plant-based diets can lower LDL about 15 to 30%, which is great. I've always said in my own experience, or what I like to do is when I have a patient come in and I think they're up for the challenge, I'll recommend that they try a full plant-based diet for 6 weeks, and we'll get labs on either end. And I typically do see, I always say 1/3, so I guess that would be 33% drop in LDL. So if someone has an LDL of 150, we can quickly get it down to about 100 adopting a fully plant-based diet. And that is very significant, and that can greatly lower your ASCVD risk and change your eligibility for a statin. Okay, so vegetarian, vegan diets, we know, reduce blood pressure by 5 to 7 points on top and 2 to 5 points on the bottom. That really doesn't sound like a lot. So I think initially adopting a plant-based diet, you may not see a huge reduction, but in time, as weight drops, that blood pressure drops further. And that's really what I see in time. Cholesterol, we see a huge improvement in 6 weeks. Blood pressure, we need a little more time to really get that down with a more plant-based eating style. So what can a plant-based diet do? Definitely improve insulin sensitivity, lower body weight, and reduce inflammatory markers. So there's a lot that a plant-based diet can also do, right? If we're improving insulin sensitivity, maybe that means you've overcome diabetes, which will also greatly reduce your heart disease risk. Okay, so statins used in primary prevention, so people who have not been diagnosed with cardiovascular disease before, may be stopped in some cases. You definitely want to discuss this with your doctor. So here's what we need in order to consider stopping a statin. So sustained lifestyle change greater than 3 to 6 months with objective improvements. So I've had patients who've, reported lifestyle improvements, which is awesome, but we haven't seen the change maybe in 2 or 3 months. So for some of those individuals, we need a little more time until we can see objective improvements in some of their parameters. So low updated risk, so ASCVD risk less than 5%, or you're sort of considered borderline if you're 5 to 7.5% with no additional risk factors. Or we also want to see that LDL is at goal before we consider stopping a statin. So definitely less than 100 for primary prevention, less than 70 to 80 in patients with other risk factors. Another item to look at if we're sort of on the fence about whether or not someone should be on a statin is getting a coronary calcium score. So sometimes we're just not sure, and I'm like, well, you have some things that would support using a statin, but you definitely are eating well and you've made so many improvements. So sometimes we'll get a coronary calcium score. If it's 0, I say, I don't think we need a statin, but if it's through the roof, then I would definitely recommend one. Okay, so as I mentioned, pop those parameters in that ASCVD risk calculator. That gives you an idea of where you are. Again, this is for people between the ages of 40 and 75. You can play with some of those. See how much, if you get your cholesterol down, see how much it changes that. Lifestyle and statins, when deprescribing is not appropriate. So prior heart attack, prior stroke or TIA, symptomatic peripheral artery disease, so you experience like claudication or cramping, poor circulation in the legs, or any past stent or bypass surgery. So statins are almost always continued in this group because the absolute benefit is large. Okay. Also, familial high cholesterol, we've mentioned this, LDL above 190, typically need lifelong LDL lowering. Obviously, if it's familial and you have a genetic component, you would have to take this long term in order to see a positive impact. Diet helps. Diet definitely helps. Sometimes I get patients who say, oh, it's familial, there's nothing I can do. And I like to change the conversation. Oh, because it's familial, it's so important that you eat well because you have this greater risk factor. So diet does help. And I have seen people in this above 190 range surprise me, and they've made a significant dietary change and they've gotten it way down. So if you are in this group and, lifestyle change gets that LDL down to 150, you may not be in that group anymore. Okay. Persistent high risk despite diet. So if you have additional risk factors like diabetes, chronic kidney disease, inflammatory disease, strong family history, or elevated lipo-A or ApoB, those are subtypes of cholesterol that can hint towards increased risk. All right. We have about 10 slides left, guys. You're doing a great job. I just have a lot to say. Okay. When deprescribing is not appropriate, also, as we mentioned, if coronary calcium score indicates, that you have plaque buildup. So definitely any score above 0, but definitely above 100, we would recommend a statin. So who decides? Yes, you do want to discuss with your doctor. Stopping on your own is unsafe, especially after a heart attack or stroke. I love deprescribing. I'm eager to help people adopt positive lifestyle changes so they can get off their medicines, but I think it needs to be done strategically. Also, I've had patients with diabetes say like, I'm doing it the natural way, and they just stop everything, but that can be dangerous. That can put you at really high risk for DKA, diabetic ketoacidosis. Anyway, it can put you at risk for all sorts of things if you stop medications before you perhaps are. Yes, shared decision-making. So you can chat with your doctor about the pros, the cons, what your preferences are, and together come up with a decision. Common pitfalls to avoid: abrupt self-discontinuation, especially in secondary prevention, having a heart attack or stroke in the past. Assuming a great LDL alone equals low risk, right? Now, I have plenty of these patients who have a great LDL, but they have other things that we need to consider. Coronary calcium score indicates plaque buildup. They have a diabetes diagnosis. They have a genetic risk factor like a high lipoprotein. So it's more than just LDL. And again, that goes back to that MD Calc ASCVD risk calculator. LDL is only part of the equation. Cholesterol level is not the only thing that matters. The real question is, what is your overall risk of heart attack or stroke? Okay, common pitfalls: deprescribing without a monitoring plan. This is another one. So there's a lot of patients sort of in the gray zone. So I say, okay, sure, let's stop it, and we'll just see you back in 3 months and check your levels again, check your blood pressure, check your A1C, and just see what everything looks like. So sometimes people stop it and we reevaluate, and I say, the numbers aren't looking good. I think we should be back on this. Or other people, we stop it, we recheck the numbers, and everything checks out. So when you stop it, make sure you have a plan down the road to check in again and recheck some of that lab. Over relying on supplements, for example, red yeast rice varies in potency and quality. It is not guideline endorsed as a statin substitute, although we see some positive benefit. We just don't have the same research behind it. So what about supplements? Yes, let's go right into the red yeast rice. So this naturally contains monocolin K, which is chemically identical to lovastatin, which is cool. So it actually is very similar chemically to a statin medicine. The only problem is, supplements are not regulated by the FDA, so effectiveness and purity are going to vary widely. Supplements just don't have the same rigorous research behind them that pharmacotherapy has. So definitely worth a try. Definitely worth a try. It's just, it would be hard for a physician to know how to endorse it without having the research to tell us exactly how effective it may be in preventing cardiac events down the road. Berberine, we may see a modest reduction in cholesterol and glucose, so people use this also for blood sugar control. Evidence is limited compared to statins, and likewise, quality control is an issue. So again, worth trying, but just more gray zone here when we get to supplements. Ones that don't have as much support, niacin. Rarely do I have patients try niacin. It causes facial flushing, which people do not like. Fish oil, cholesterol, sort of mixed results on some of these. The McDougall program likes cholesterol, so that is one that I've tried a lot. And I've had some patients have success with it. Other patients, I'm always willing to try something. It just comes down to the lab work. So let's just try them and see if they work. It seems like supplements may be more impactful in some people than other people. And I don't know if that's because we are genetically different or because, patients, some may have a quality product and others may not. So just a lot of question marks around supplements. Bottom line, supplements may help in addition to lifestyle, but they are not a proven substitute for statins when medication is clearly indicated. Statins are standardized, tested, proven to reduce heart attacks and strokes, and should not replace prescribed therapy without careful discussions. Always something to discuss. Another key point. Statins are not a failure of lifestyle, but rather one piece of a broader prevention strategy. I definitely get it. Nobody wants to be on medication. But I think you should really look at the big picture when you're making that decision. Because I think for most of us, the goal is to live a long and healthy life. And yes, medications are an inconvenience. But if you have that discussion and a statin is recommended, you may be better off in the long run taking. For some, they are lifelong. For others, like I mentioned, they may be temporary. It may be something. And sometimes it's a wake-up call. I get a person in, I'm saying, look, looking at your risk right now, you really should be on a statin. That may be just the wake-up call they need to make some major lifestyle changes so that they are no longer eligible for a statin. The best outcomes come from combining healthy living and evidence-based medical care, which is what I try to do for patients. Statins, again, are one tool in the toolbox. Obviously, we want to make positive lifestyle changes and adopt plant-based diets. That's a very powerful thing we can do, but we should also, consider how statins can help us meet our long-term goals. Okay, questions. I see we have some already. With an anomaly with the coronary calcium score of 0, but a very high lipoprotein A and a smidge high on the LDL, but not horrible on LDL. My mind has changed about statins if I need to go. That's definitely the gray zone. I always consider the coronary calcium score the tiebreaker. If I have a patient who clearly has some risk factors, but I know they also eat well, it's a little bit up in the air. So if you have a coronary calcium score of 0, that means you have no calcified plaque. Now, it doesn't rule out soft plaque. You may still have soft plaque. Soft plaque is reversible with positive dietary changes. But truthfully, from my perspective, if you have a coronary calcium score of 0, I'd say that's pretty good. And let's just keep monitoring you, not necessarily with that, but once a year with, weight and blood pressure, lipids, etc., just to make sure we stay on that path. And you can always get that done down the road. I definitely wouldn't get it annually, but if you wanted to maybe get it every 5 years just to see where you are, that's reasonable. Is it safe to take red yeast rice if you are already on statins? That's actually a good question because it is chemically similar to lovastatin. So I'm going to have to look that one up and then I'll post an answer in the group. I haven't heard, that's nothing I've ever heard of that you can't take it. I guess the question is, is that just redundant therapy? You may not be getting much benefit if you're already on a statin. So I don't know, but I'll look that up and post something in the group. Good group, as usual. I will go ahead and get this recording up in a month, and then I can always do additional, or if anyone has any additional questions they have or topics they want covered, we will cover whatever you want. I think coming up, I might do next month, like reflux, a similar talk about reflux medicines. What are the alternatives, side effects, etc. So might do reflux, but if you guys have better ideas, I'm always open to whatever people want to discuss. All right. Well, thank you guys so much